Hi guys, welcome to Prepladder NEET-SS. Dr. Patil here, and in this video module, we will be learning about chronic obstructive pulmonary disease. As a postgraduate student, you have already presented n number of cases of COPD, and COPD as a clinical entity is something that most of us are very much familiar with. So today's focus will be mostly on trying to address the key MCQ points. Okay, now the moment I say COPD, we know that there are two phenotypical variants. One is chronic bronchitis and the other one is emphysema. And all of us are also familiar that most of the patients that we see in today's clinical practice have a significant overlap of features. It is very difficult to see patients with the pure emphysema variant of COPD or patients with pure chronic bronchitis variant of COPD. Right. Now, we typically describe a patient of emphysema as someone who is lean, cachexic, and non-cyanosed. And his main reason for presentation to hospital is with dyspnea. So dyspnea is his main complaint, though he is not grossly hypoxic. And this typical patient, when examined, might have significant air trapping leading to barrel chest. That's the typical description of a patient with emphysema. Now, when you describe a typical patient of chronic bronchitis, you say that someone who is overweight or kind of loaded with fluids, right? So it's like a patient with right heart failure secondary to chronic bronchitis or COPD, presenting with edema, raised JVP, may be palpable, liver, and when you see him, mostly he may be cyanosed. So there is significant cyanosis secondary to significant hypoxia. That's the usual description of a patient with chronic bronchitis. So on one hand, you have a lean cachexic patient presenting with dyspnea, and on the other hand, you have someone who is edematous presenting with cyanosis and hypoxia, and obviously dyspnea secondary to that. Okay, now how do you define these entities? Now, chronic bronchitis is defined as presentation with chronic cough which is productive for at least 3 months or more than that per year for 2 consecutive years. That's the definition of your chronic bronchitis. So basically, chronic bronchitis, the definition stems from the clinical understanding of the disease. On the other hand, emphysema, the definition is pathological. So here we define emphysema as a variant of COPD where there is irreversible destruction of alveolar wall. Irreversible destruction of alveolar wall. That's the definition of emphysema. Okay, going forward, we will understand a little bit about the pathogenesis of both of these. Now, let us move at understanding the epidemiology of COPD. If there's a question asking you what are the risk factors, obviously most of us would say the single most important risk factor for the patient to develop COPD is smoking. Now, during your general bedside discussions, often examiners ask, can we correlate with the pack years and the risk of COPD? Obviously, the answer is yes. Right? The pack years correlate with the risk of COPD. And this is one statement I want you to remember. Pack years do correlate with risk of COPD. So generally speaking, how many pack years should be considered as a significant risk factor for development of COPD? That is around 15 pack years. Right? Okay, so for those of you who are not aware what is pack year, it is derived by multiplying the number of packs of cigarettes smoked per day into the years where the patient had smoked. So it's like a patient with 5 years history of smoking where he was on an average smoking 2 packs of cigarettes per day. That would be like 10 pack years, right? Okay, so 15 plus pack years starts increasing the risk of developing COPD. Okay, now what is the contribution of smoking as a risk factor? Majority of the patients of COPD that we see today are smokers. So it's definitely a risk factor, but it only accounts for, as the Harrison makes a statement, it only accounts for around 15% of the variability in FEV1. Accounts for around 15% of variability in FEV1. See, patients with COPD are significantly reduced FEV1. They have a significantly reduced FEV1. Patients, according to gold staging, might be classified with stage 3 or stage 4 eventually, and at that point of time, the FEV1 reduction is less than 30% for gold stage 4, less than 50% for gold stage 3. Now, those patients, now the variability can only be accounted by 15%. So, smoking is not the only important risk factor. Probably there are other important genetic as well as environmental risk factors, some of which we have understood so far, and some of which are yet to be deciphered. Okay. Now, what about the additional risk factors like air pollution? Okay. Now, in case of smoking, clearly a cause-effect relation is well established, right? So, in case of smoking, cause-effect relation is well established. So, we can consider smoking as a causal agent. But in case of the air pollution, I cannot say so. So, it might be associated with increased risk, but cause-effect relation is not well associated. Cause-effect relation is not established. Is not established. So you need to remember this, because there may be an MCQ on this, whether it is considered as a causal agent for development of COPD. Right now we don't have evidence. Probably it does play a role. Most of the practitioners, most of the researchers do believe, but we don't have evidence, or we don't have data to back it up. Okay. Now in that case, we do see patients who are non-smokers and they present with COPD. For example, we do see Indian females presenting with COPD. The prevalence of smoking is very less than what accounts for the risk of COPD. So another entity where the cause-effect relation is well established is burning biomass fuel. Burning biomass fuel, mainly for cooking, right? Biomass fuel. So the Indian chula, where we burn cow dung patties or your wood logs, the smoke emanated from that can be considered as a risk factor for development of COPD. And here we have some evidence to say that the cause-effect relationship can be established, right? So here we have cause-effect relation well established. Cause-effect relation is well established in case of burning biomass fuel. And if there is a question asking you, in case of Indian women, what is the most common cause for COPD? This is the most common cause for COPD. Burning biomass fuel is the most common cause for COPD among Indian women. Okay. Obviously, among Indian men, it is definitely going to be the smoking, but in females, it is the burning biomass fuel. Okay. Now, these are important environmental risk factors. What about genetics? Definitely, that's going to play an important role, right? Because as I have already told you, only 15% of the FEV1 variability in patients with COPD can be accounted for by the smoking, right? So remaining has to be accounted for by other measures. So when you look at genetics, I think the first thing that should come to our mind is obviously alpha-1 antitrypsin deficiency, right? Alpha-1 antitrypsin deficiency, or AATD. Now, to what percentage of COPD patients do suffer from alpha-1 antitrypsin deficiency? Okay, so we need to note that around 1% of COPD population of the Western world, like we don't have Indian data, 1% of whites, right, have COPD where alpha-1 antitrypsin deficiency is also seen. We don't have Indian data, as I've already told you. So this stems from the Western world. Okay, now why there is increased risk of COPD? This you clearly understand. In case of alpha-1 antitrypsin deficiency, which is coded by a gene called as SERPINA1, right? Now this codes for a serine protease inhibitor. Serine protease inhibitor. So this is a protease enzyme inhibitor. The important proteases that it inhibits is mainly elastases. Elastases are the important proteins that it inhibits. Now, if there is an imbalance between proteases and antiproteases, increased protease activity would occur. Like if there is reduced amount of antiproteases present, reduced amount of alpha-1 antitrypsin present, that will lead to unchecked activity of elastases, and that elastase will cause tissue destruction, and that tissue destruction is what manifests in the form of emphysema, right? So that leads to development of emphysema. So in case of alpha-1 antitrypsin deficiency, mostly patients develop emphysematous COPD. So they are most likely phenotypically going to have emphysema predominant form of COPD. Okay, and when we talk about emphysema predominant form of COPD, we should also know what kind of emphysema is likely to be seen in alpha-1 antitrypsin deficiency. Okay, so when you talk about smoking, there it is usually, in case of smokers, it is usually centrilobular, but in case of alpha-1 antitrypsin deficiency, it is likely to be pan-acinar or panlobular. Pan-acinar emphysema. Pan-acinar emphysema. Okay, remember this point also. In case of smoking induced emphysema, it's likely to be centrilobular. Centrilobular. Okay, so this is an important MCQ point. In case of smoking, it is centrilobular. In case of emphysema, it's pan-acinar. Okay. Now, if you know that COPD patients, around 1% of the global population, of mostly data coming from the Western world, suggests that there is alpha-1 antitrypsin deficiency among them. Should we screen all patients for alpha-1 antitrypsin deficiency, all COPD patients? The answer is yes. Now, the American Thoracic Society and also WHO, ATS and WHO recommend, they recommend, highly recommend alpha-1 antitrypsin level estimation in all COPD patients, So this is again one more important point I want you to remember. This is again a potential MCQ point. Okay, how practical it is for Indian scenario, I don't know, but this is the standard recommendation. Okay, now that's about genetics. Yeah, we also need to talk a little bit about other additional genetic factors. Alpha-1 antitrypsin deficiency is one. Other than that, we have also identified certain other genetic variants using the GWAS studies. Obviously, when I talk about GWAS studies, their risk contribution, like the genes that we have identified based on the GWAS studies, the risk contribution is at best modest, right? So as standalone genetic abnormalities, they are not likely to lead to development of COPD. So multiple factors where this can be one of the contributor, right? So GWAS studies have identified variants of genes called as HHIP, then FAM13A and IREB2. These variants are associated with, certain variants are associated with increased risk of developing COPD. Okay, so that's about genetics. Now talking about the pathology, what are the changes we are anticipating when we see a patient with COPD? Now COPD is a disease which affects, predominantly it's a disease of the small airway where there is airflow limitation or obstruction, right? So there is involvement of small airways and that's the most important part. But apart from that, we do see changes in terms of central airway or large airways, small airway or peripheral airways, as well as central or large airways. Okay, apart from that, there is also lung parenchymal changes present. Lung parenchyma is also affected, and to some extent pulmonary vasculature is affected, right? So we need to talk about what are the changes that happen in these four areas. When we talk about the small airways, what are the changes that we can anticipate? Number one, you need to know that there is goblet cell and mucus gland hyperplasia. Mucus gland hyperplasia. Okay, so this mucus gland hyperplasia leads to increased mucus production, and this increased mucus production might lead to small airway clogging. Small airway clogging. So that's one of the change that we would be seeing. Okay. Apart from that, do we see any other important changes in COPD? There will be obviously inflammatory infiltration. So there will be inflammatory infiltration, mostly neutrophilic and to some extent lymphocytic. Okay. Will there be eosinophilic infiltration? Well, that's a bit of a controversial topic because we do see patients with COPD where the peripheral eosinophils are elevated and airway biopsy specimens or the BAL fluid does show that there is increased eosinophil present. But the debate is whether those patients also have an element of asthma overlapping the COPD, which is quite a possible. So we recognize asthma COPD overlap as a well-known entity, right? Okay, so the inflammation is predominantly derived from the neutrophils and lymphocytes rather than eosinophils. Okay, now what happens to the basement membrane of the airway epithelium? Will that be affected? Basement membrane, will that be affected? The answer is generally not affected. So this is one point where it is different from bronchial asthma. So in bronchial asthma, as we discussed in the bronchial asthma video, the basement membrane thickening is a standard finding. Here we do not see basement membrane thickening. Okay. Apart from that, we should also note that in case of small airway involvement, what about the smooth muscle layer? Will it be hypertrophied as in case of bronchial asthma or not, right? So the answer is it is not hypertrophied. Smooth muscle, there is no hypertrophy. There is no hypertrophy or hyperplasia, unlike in case of your bronchial asthma. So one more factor which kind of correlates in case of bronchial asthma with the variable obstruction, because there is smooth muscle hypertrophy which is playing an important role in the bronchospasm. More the hypertrophied muscle, more intense is going to be the bronchospasm, right? And once you cause the bronchial relaxation using bronchodilator, you will see a good response. In case of COPD, the smooth muscles are not the main contributor for bronchial obstruction. It is the inflamed airway, the mucosal edema, and the production of mucus which is clogging the airway. That's what is responsible for bronchial obstruction. So that's why it is largely irreversible, or the response to the short acting beta agonist is going to be minimal, right? Okay. Now what happens in case of central airways? The same thing in case of central airways. Again, there is goblet cell as well as mucus gland hypersecretion or hyperplasia, leading to increased mucus production, and there is also airway inflammation. So this increased mucus production is the characteristic finding of what we talk about chronic bronchitis. So in case of chronic bronchitis, this is one of the important pathology change that you will be seeing in small and central airways. Okay, now what are the changes that you would see in lung parenchyma? Parenchyma, basically there will be destruction of alveolar wall and the septal. Alveolar wall and septal destruction will be there, which is irreversible. Right? So that's the parenchymal changes. Typically parenchymal changes are more pronounced in case of emphysema variant of COPD. On the other hand, the airway inflammation and the goblet cell and mucus gland hyperplasia is more likely to occur in case of your chronic bronchitis variant of COPD. That's the predominant abnormality. Okay, now obviously in COPD there is hypoxia, and this hypoxia does lead to certain changes in the pulmonary vasculature. So hypoxia is a potent stimulus for increase in the pulmonary vascular resistance. So this hypoxia will lead to increase in pulmonary vascular resistance, or indirectly I can say it will cause vasoconstriction, pulmonary vasoconstriction, and this certainly leads to development of pulmonary hypertension. And once the pulmonary hypertension occurs, there can be right ventricular hypertrophy, obviously, right? And a hypertrophied right ventricle will eventually fail, right? So then once you have a right ventricular failure, after that, or right heart failure, after that you start seeing the raised JVP, peripheral edema, hepatomegaly, the typical manifestations of right heart failure, and that is the point where you start calling it as cor pulmonale. Okay, so this again is more likely to occur in patients with chronic bronchitis. Okay, so that is the pathology we are talking about. Now talking about the pathophysiology, how the patient of COPD, starting from the environmental and genetic factors trying to trigger the inflammatory response, eventually leading to development of chronic bronchitis and emphysema occurs. Okay, so we have to first understand, in case of chronic bronchitis, pathophysiology wise, what is the main difference between emphysema and chronic bronchitis? Okay, so remember, emphysema, there is no ventilation perfusion mismatch. In case of chronic bronchitis, there is a ventilation perfusion mismatch. So if there is ventilation perfusion mismatch, that's certainly going to lead to development of hypoxia, and this hypoxia lead to pulmonary vascular changes, and this hypoxia also leads to what can I call as erythrocytosis or polycythemia, right? So a good number of manifestations are related to the changes in the pulmonary vasculature in case of chronic bronchitis. Physical symptoms are basically related to increased mucus production and cough. Okay, in case of emphysema, the VQ mismatch does not occur, but there is air trapping. So because of this, there is not much of hypoxia. It's not much of hypoxia in their blood, and they will be able to maintain the saturation well. So because of that, they typically do not present with a right heart failure. That's why generally patients with emphysema are cachectic and not bloated with fluid. Okay, but because there is air trapping, that leads to increased work of breathing, and patients present with dyspnea. That's how these patients come to hospital, right? So the take home message is very simple. The main difference is, in case of chronic bronchitis, VQ mismatch does occur. In case of emphysema, VQ mismatch doesn't occur. So why there is no VQ mismatch in case of emphysema, we will talk about in a bit. Okay, so this flowchart will kind of make it very simple for you to understand. In case of chronic bronchitis, which you often describe as blue bloater, cyanosed and a bloated individual, right? So in case of chronic bronchitis, airway obstruction, because of all the pathological changes that we have seen, lead to one, wheezing. That's how these patients can present to hospital. And obviously there is alveolar hypoxia because of the airway obstruction, and this hypoxia leads to VQ mismatch. So perfusion is unaffected in case of chronic bronchitis, but ventilation is affected, and this mismatch leads to development of hypoxia and also carbon dioxide retention leading to hypercarbia. Now, this hypoxia will lead to development of polycythemia, and this hypoxia can also be responsible for the pulmonary vasoconstriction. Right? Once the alveolar ventilation is not good, there can be pulmonary vasoconstriction, and this pulmonary vasoconstriction will lead to pulmonary hypertension. Now, this pulmonary hypertension will result in two important things. The right-sided heart fails because the pulmonary hypertension will cause right ventricular hypertrophy. Hypertrophied right ventricle may not be compensated with increased coronary vasculature. So there is a mismatch between the blood supply and the demand to the right ventricle. So the right ventricle will eventually fail and dilate. That's what we call as cor pulmonale. So clinically, when we see patients with cor pulmonale, you will have a raised JVP, loud P2, and a right parasternal heave. Right. Now, if the pulmonary hypertension occurs, there can also be reduction in the left ventricular output. Why there will be reduction in the left ventricular output? Because the right ventricular output is reduced. Now, if the RV output is reduced, then the amount of blood going to the lungs is reduced from the pulmonary artery. And if the blood going to the lungs is reduced, the blood coming back to the left atrium is reduced through pulmonary veins, and obviously that means the amount of blood coming to the left ventricle is also reduced. So LV output gets reduced. So this reduced LV output also leads to decrease in the effective circulating volume, and that would lead to activation of the renin-angiotensin-aldosterone system, and that will lead to fluid retention. Right. So this is one arm of the pathophysiology. The other thing we will notice is the hypercarbia in case of your chronic bronchitis will also lead to respiratory acidosis. Sometimes that can lead to patient presenting with what is called as CO2 narcosis or hypercarbic encephalopathy. CO2 narcosis or hypercarbic encephalopathy. Right. So this is the pathophysiology of your chronic bronchitis. Now, how emphysema pathophysiology is different? In emphysema variant, as we have already understood, predominantly there is a parenchymal involvement apart from the involvement of the airway to some extent, right? So because of the parenchymal involvement, the alveolar wall and septae are destroyed, so that leads to alveolar detachment, and because of the parenchyma being affected, the elastic recoil of the lung is reduced, right? It is able to get stretched when the air comes in, but the recoil is reduced, and because of that, emptying the air during exhalation becomes increasingly difficult, right? Okay, so alveolar detachment will lead to air trapping on expiration. That's exactly what is known as autopeep, and patients might compensate for that by pursed lip breathing. So pursed lip breathing is more typical of your emphysema patients. Okay, and this air trapping also leads to increase in the end expiratory volume. So eventually the residual volume, total lung capacity will increase, and the vital capacity would decrease, leading to barrel chest, right? Your anteroposterior diameter more than your horizontal diameter. Okay, then there is also destruction of the capillary bed, and this is one important point I want you to note. Okay, I'll come back to this in a bit. Now, the decrease in the elastic recoil also increases the lung compliance, and increased lung compliance means the reduction in terms of ventilation. Why reduction in terms of ventilation? Because exhalation becomes increasingly difficult. When lung compliance increases and more air is being trapped, your diaphragm descends down. This descent of diaphragm down itself is responsible for various hemodynamic changes. One of them is also increased difficulty going forward with respect to inhalation, because inhalation is mainly caused by what? Diaphragmatic descent and build-up of the negative interthoracic pressure. If diaphragm is already descended, then the available space for further descent during inspiration to generate that negative interthoracic pressure is limited. Patients find it increasingly difficult to generate the negative interthoracic pressure to cause inhalation. So inhalation, exhalation both start getting affected. Okay. Now this increased lung compliance is responsible for decrease in ventilation and the destruction of capillary bed in case of emphysema. As part of the parenchymal destruction is responsible for reduction in the perfusion. So perfusion and ventilation both are reduced. So the end result is you have a VQ match. There is no VQ mismatch. Matched VQ defect. And because of this, like the overall ability of the system, your lungs system, the ability to oxygenate blood is reduced, but whatever blood that comes to the lungs gets decently oxygenated. Okay, so you have a relatively well oxygenated blood until late stages in case of emphysema. That's why these patients do not present with cyanosis. And because the VQ mismatch doesn't occur, these patients do not develop the right ventricular failure. Right? Pulmonary vascular resistance doesn't increase, the changes in the PVR are not occurring, and patients do not develop pulmonary hypertension. So the chances of them developing right ventricular failure or right heart failure is reduced. Okay. Now again, because of the destruction of the capillary bed, the diffusing capacity is reduced in case of emphysema. So DLCO is likely to be normal in your chronic bronchitis patients, and in case of your emphysema patients, the DLCO will be reduced. Now if there is a question asking you what happens to DLCO in COPD without stating whether you're talking about chronic bronchitis or emphysema, your answer should be it is reduced. Is to know that why I say that this is reduced. I say it is reduced because two important reasons. Reason number one, now when you see patients of COPD overall, mostly you don't see one phenotypic predominance. Like you don't see a typical patient with pure chronic bronchitis or a typical patient with pure emphysema. Most patients have overlapping features, and that's why most patients have reduction in DLCO. Okay. The second important reason is emphysema patients are relatively common in comparison to chronic bronchitis. So that makes us to choose reduction in DLCO as an answer if the question is generally asking about COPD without specifying the phenotype. Okay. Now this increased lung compliance increases the work of breathing, and obviously when the work of breathing increases, patient presents with dyspnea. Okay. Now apart from that, in case of COPD itself is a hyperinflammatory state. One of the important cytokine you need to remember which is responsible for inflammation in COPD is TNF alpha. This TNF alpha is responsible for patient developing cachexia. Okay, and hyperinflammatory state might also lead to osteoporosis and accelerated atherosclerosis, leading to heart disease, mainly coronary artery disease. So one of the important causes for mortality in COPD patients is coronary artery disease. If mortality occurs in COPD patients due to coronary artery disease, it is likely to be 3 to 5 years on an average, earlier than the general population, right? So that's the pathophysiology of your COPD. Okay. Now before we move forward, just a quick look at the emphysema. Now I have already told you about the emphysema. Emphysema can be of two variants with respect to COPD. One, it is pan-acinar, the other is centri-acinar or centrilobular, or pan-acinar or pan-lobular. In case of pan-acinar, all the respiratory spaces including alveoli are affected. In case of centri-acinar, only respiratory bronchioles sparing the alveoli. So centri-acinar is typical of smoking, and it mainly affects the upper lobes and to some extent posterior lobes. Lower lobes, it is the upper segments which are affected, right? So typically you have to remember upper lobes, smoking, upper lobe. And in case of alpha-1 antitrypsin deficiency, it is bases, right? So lower lobes of the lungs are more affected in case of the pan-acinar, which is due to alpha-1 antitrypsin deficiency. If you feel it is a bit difficult to remember or get confused in the exam, let me make it very simple. Okay, when you smoke, I generally say this as a mnemonic. So when you smoke, you feel high. So that way you can remember smoking leads to upper segment, higher segments or higher lobes of the lung being affected, right? So upper lobe and upper segments of the lower lobes, because we feel high when we smoke. On the other hand, if you're diagnosed with a genetic disease, you feel very low. Like if I tell you that, okay, you have a genetic disease, obviously you're going to feel very low. So that way you can remember that lower lobes or bases of the lungs, which are usually affected in case of alpha-1 antitrypsin deficiency, right? Okay, so that's about the pathophysiology, and now it's time for us to talk about the diagnosis. Now, how do you diagnose a case of COPD? Number one, it is a PFT based diagnosis. A good clinical history is very much essential, because without a good clinical history, probably you may not suspect. But in any case of smoker presenting with history of cough, which is chronic or persistent, you should think of chronic bronchitis as a possibility. And any case of smoking presenting with dyspnea as a complaint, apart from chronic bronchitis, you should also think the emphysema variant of COPD as a possibility, right? Now, once you suspect, you need to look at the PFT. Now, when you do PFT, what are the observations we will be looking at? Number one, this is a obstructive lung disease, so we will be looking at FEV1. Then we will be looking at FEV1 by FVC ratio to call it as obstructive lung disease. So FEV1 will be reduced. Normal is more than 80% of predicted. In COPD patients, that's normal, more than 80% predicted. In COPD patients, it will be less than 80% of predicted. Okay. Now, when you look at the FEV1 by FVC ratio, FEV1 by FVC ratio, normally in normal individuals and those who do not have an obstructive lung disease will be more than 70%, right? So that's the normal, more than 70%, that's normal. In COPD patients, it will be again reduced, so it's likely to be less than 70%. Okay, but we also recognize a variant of COPD called as PRISM COPD, which I want you to remember. This is like a potential MCQ point. PRISM COPD. What is PRISM COPD? As the name says, PRISM. PR stands for preserved ratio and ISM stands for impaired spirometry. Preserved ratio and impaired spirometry. That means in case of PRISM COPD, the FEV1 is reduced. So that means the spirometry is impaired because the FEV1 is reduced, but the ratio is preserved. That means FEV1 by FVC ratio is normal, or it is going to be more than 70%. So that's a variant of COPD. It's called as PRISM COPD variant. And with this regard, Harrison mentions a statement which I want you to remember, that PRISM COPD is a subgroup of patients with FEV1 less than 80%, but FEV1 by FVC more than 70%. These patients tend to develop emphysema late and can directly progress to gold stage 3 or 4 because FEV1 is reduced, and these patients might get catapulted into gold stage 3 or 4 rapidly. Instead of slowly progressing through the gold stage 1, 2, 3, 4, they can rapidly progress to stage 3 or 4, right? Okay, so that's about the PRISM variant of COPD. Now coming back to the diagnosis, this is what we will be looking at in the PFT. FEV1 by FVC ratio has to be less than 70% in a typical case, barring the PRISM variant, and FEV1 will be reduced. Now, this picture of PFT obviously resembles your bronchial asthma because that's also an obstructive lung disease. So, how do we differentiate between these two? The main differentiation is from the bronchodilator reversibility test. Bronchodilator reversibility test. Right. So, when you talk about asthma, we generally describe asthma as an obstructive lung disease with variable obstruction, right? So, asthma is a obstructive lung disease where there is variable obstruction or reversible obstruction. So, it's mostly because of the increased bronchospasm. So, that can be reversed by administration of a short-acting beta agonist. So, we need to demonstrate in case of bronchial asthma that this obstruction is largely reversible. And in case of COPD, we need to demonstrate that it is not well reversible. How can we do that? We can do that by doing what is called as bronchodilator reversibility test. Now, how do we do this bronchodilator reversibility test? We administer a short-acting beta agonist like albuterol in a inhaled form, right? Albuterol inhalation, and 15 minutes later, 15 minutes after administration of a short-acting beta agonist, patients FEV1 will be looked at, and if the FEV1 increases from the baseline by more than or equal to 12%, that should be considered as asthma. And when this, even if increases, right, the increase is less than 12% from the baseline, the FEV1 increase less than 12% from the baseline before the bronchodilator reversibility test, then you will consider this case as COPD. So, in COPD, there is obstruction that we have confirmed by looking at FEV1 by FVC ratio and FEV1, and to differentiate it from bronchial asthma, we have done a bronchodilator reversibility test, and the FEV1 here will not increase by more than 12%. Though at some point of time, Harrison does mention that up to 15% you might see in COPD. So, we still need to depend little bit on clinical judgments, particularly COPD asthma overlap variants. You might see the bronchodilator reversibility demonstrating 12 to 15% improvement in the FEV1. So, it's like not a hard and fast rule to say that, okay, if you have 13% improvement on the FEV1 after administration of albuterol, that does not mean it has to be bronchial asthma. There's still possibility that it could be COPD. So, we have to remember this point. Now, by definition, this is what we talk about, but for clinical diagnosis, you still need to rely a little bit on your clinical judgment. Okay, now what are the PFT parameters we might see, or what are the PFT parameters that can be asked as an MCQ? So, in case of COPD, apart from your FEV1 by and FVC ratio, the residual volume may be increased because of the air trapping, and the residual volume by total lung capacity ratio may be increased, and eventually there will also be increase in the total lung capacity, right? So, these are the additional PFT abnormalities that you need to remember. Increase in the residual volume, increase in the residual volume and total lung capacity. That's initially, eventually even the total lung capacity in case of COPD will be increased, right? Okay, so that's about the PFT. Now, do we need the chest X-ray for diagnosis? Mostly we end up doing it, not mandatory, but we end up doing it. So, if you do a chest X-ray, you might see that there is airway inflammation. Now, you might see that there is airway hyperinflation. So both lung fields might show hyperinflation, hyperinflated lung fields, and apart from that you might see emphysematous bullae at some points, emphysematous bullae in some areas, and you will see flattened diaphragm, widening of rib spaces. These are the important changes that you would be appreciating. Okay, and in COPD typically we describe a tubular heart, and most of these changes are very peculiar of emphysema. So in case of chronic bronchitis, the max you will see is increased bronchovascular markings and evidence of pulmonary hypertension on the chest X-ray, and probably nothing more than that. Okay, so this is about the diagnosis. So as I've already told you, diagnosis is going to be mostly based on your PFT and a good relevant clinical history. Okay, so that concludes the part 1 of the COPD. In the part 2, we will discuss about the management of COPD according to the current GOLD guidelines.